All right, today we are pulling the mask off a true medical chameleon, hypoparathyroidism. We're talking about a condition that loves to dress up as a primary psychiatric illness. We're going to break down how you can spot it so you never get fooled.
So picture this. You have a patient with anxiety that just isn't getting better, no matter what you throw at it. They're complaining about this persistent brain fog. You've gone through the whole playbook, but nothing is working. Well, this is the classic setup for our great masquerader. And it begs the question, are we missing something big?
If there's one single thing you take away from all this, I want it to be this phrase: a calm brain needs calcium. It's so simple, but it's the key that unlocks this entire diagnostic puzzle. This is our guiding light today. So here's our game plan. First, we'll talk about the calm brain's enemy. Then we'll unmask the usual suspects causing the problem. We'll look for the body's telltale signs before diving into the mind's excitable state. And finally, we'll nail down how to confirm the diagnosis and wrap it all up with some clinical pearls you can start using tonight on call. Okay, first up, the calm brain's enemy. The fundamental problem here isn't really a software problem of thought or mood, it's a hardware problem. It's about electricity and chemistry. What we're really talking about is neuronal hyperexcitability. So what does that actually mean? Well, think of calcium as the steady, calm bouncer standing at the door of every neuron, keeping things in check. When your calcium levels drop, that bouncer just disappears. Suddenly, the door's wide open, the threshold for firing plummets, and your neurons start firing off way too easily, completely erratically. And that chaos is what creates this huge range of neuropsychiatric symptoms. Okay, so if low calcium is the problem, what's causing the low calcium? Let's dig a little deeper and unmask the culprits behind hypoparathyroidism. Here's a really handy mnemonic: cut, crash, congenital, and chaos. But the one I really need you to burn into your memory is cut. By far, the most common cause is post-surgical, accidental damage to the parathyroid glands during a thyroid surgery. So if you ever see a patient with a thyroidectomy scar and new psychiatric symptoms, your alarm bells have to go off. So while the brain is in this chaotic, excitable state, the rest of the body is often sending out its own SOS signals. Let's look at the body's telltale signs. These are the physical clues that can steer you away from a purely psychiatric diagnosis. See, that neuronal hyperexcitability isn't just in the brain. It's everywhere. It shows up as muscle cramps or even painful carpopedal spasms in the hands and feet. You might also notice some subtler things, like really dry skin or brittle nails. But this is absolutely crucial. It can mess with the heart's electrical wiring, causing a prolonged QT interval on an ECG. That's a huge red flag for life-threatening arrhythmias. And check this out. Here are two classic physical exam signs you can do right in your office. For the Chauvis-Stech sign, you just tap on the facial nerve right in front of the ear. A positive sign is a twitch of the facial muscles. For Trousseau's, you inflate a blood pressure cuff for a few minutes, and you'll actually induce that characteristic carpal spasm. Seeing either of these is a massive, massive clue. All right, let's get to the heart of the matter for us in psychiatry, the mind's excitable state. This is exactly where hypoparathyroidism earns its reputation as the great psychiatric masquerader. I mean, just look at this spectrum. It can be anything from vague complaints like brain fog to our bread and butter like anxiety and depression. But then it can also show up in really dramatic ways, like in acute psychosis or seizures that won't stop. This is precisely why it's so tricky. The symptoms fit perfectly into our neat little DSM boxes, but the root cause is completely metabolic. Now, in the long term, we can see a major clue on imaging. You see, chronic low calcium and high phosphate can actually cause calcium to get deposited in the brain, especially in the basal ganglia. If you ever see this on a CT or MRI report for a patient with psych symptoms, that is a gigantic red flag. You have to think metabolic. But here's the good news. Once you suspect it, you don't have to guess. Confirming the diagnosis is actually incredibly simple. All it takes is a basic blood test. So here it is, the classic lab pattern. You're going to see low serum calcium, obviously. But here's the key. Instead of the parathyroid hormone, or PTH, being high to compensate, it's either low or, and this is the sneaky part, it's inappropriately normal. The body just isn't responding right. And because of that, serum phosphate climbs up. That low, low, high pattern, that is your smoking gun. Okay, let's wrap this all up and bring it home. What are the absolute must-know, high-yield takeaways for your next shift? These are your clinical pearls. This right here is your mental checklist. When do you order a serum calcium? Any patient with a first episode psychosis, any patient with new onset seizures, any patient with stubborn refractory anxiety, especially if they mention muscle cramps. And this one's non-negotiable. Any patient with a history of thyroid surgery who comes in with new psychiatric symptoms. Period.
And this is the bottom line, the ultimate principle. In any of these cases where things just feel off, remember your differential diagnosis. Before you stamp on a label of schizophrenia or GAD, you have to rule out the metabolic cause. Treat the calcium first.
I'm going to say it one more time because it is that important. This combination, basal ganglia calcification on a scan, plus any psychiatric symptoms, it should automatically flip a switch in your brain. Your first thought shouldn't be psychiatric. It has to be metabolic. So I'll just leave you with this question. The next time a patient comes in and their story is confusing or their symptoms just aren't responding, after this, are you going to remember the great masquerader? The next time you see psychosis, will you think of the parathyroid?